guidelines says something like 1 to 2 years. If you look at the actual printout from the USPS guidelines, which follow below, every 2 years, right? So USPS, they have guidelines every 2 years. That 1 to 2 year came in partly because Radiological Society recommends every year. So that's that confusion. USPS have guidelines. Breast screening is what? Every 2 years. All right. What?
I don't know.
Last night, one of my old corpsmen called me telling me they're applying for MESIP. You guys know what MESIP is? So it's like a nurse corps commissioning kind of Yahoo stuff, right? Before I started talking trash about nurses, any nurses in here? Damn it, can't talk trash. Last class we had an ICU nurse, dude. All right, nurse corps. All right. And on the Navy side, we talk a lot of crap about nurses, right? Just because we can. And it's the nurse corps mafia, and they got a bunch of like admirals, so they get their way and we get stepped on because we don't. Right? But nurses can save your bacon, right? So be kind to your nurses. When I was going through the ER fellowship, we do a couple months of ICU time at Scripps Green in La Jolla, which is where all the patients who are like sickly could be, right? So all my patients on the ward are all intubated, bunch of liver transplants, renal transplants, people who just want to die on you all night. That's why I hate inpatient medicine, right? So, like my second day on the rotation, there's a female civilian resident who's rotating through the program. She was a little bit snarky, right? Second she found out as a PA, it was like, oh, you're one of those, right? Got it, see where she's coming from. So that night I walk in for my shift and all the docs out there, all the attendants, super smart. All critical care pulmonologists, it's a great rotation. You get to do a lot of procedures, intubations, central lines, the whole 9 yards. And you get really good at reading x-rays because we read a bunch of x-rays every day, chest films in particular. Anyway, I get there and they're all huddled around looking at these x-rays. And attendees do what attendees like to do, so they're pimping everybody and saying, hey, what do you think's going on with this patient that we just admitted in bed 5? And they looked to her, the resident, and she said something not smart, right? So she decided, hey, let's turn the attention to me. And she's like, all right, so what do you think it is then? And it's a very condescending way. And out of nowhere, absolutely nowhere, I said, well, I think it's Lemaire's syndrome, right? And I was right. So up to 2 days before that, I never heard of Lemaire's syndrome in my life, right? Never in my life. At this point, I'm a PA, I was an IDC, I did 2 tours, never heard of Lemaire's syndrome. Working the ER shift with Dr. Drew. Anybody know Dr. Drew? ER guy, so Captain Navy, did everything in the Navy possible as an ER guy, right? So I'm working with him one night, and I saw this patient had a sore throat. Said, hey, boom, I'm sending him home. And then he came to me and goes, how do you know that wasn't Lemaire's syndrome? Lemaire's, right? And then he got distracted, so I jumped on UpToDate, did all my research on Lemaire's syndrome, right? Which turns out to be this really bad thing that people die from, right? Never heard of it in my life. And it turns out we had a patient on the ICU who had Lemaire's syndrome, and I made a diagnosis, right? Big mistake, right? Because now all the attendees think for some reason that I know what I'm doing. And I am clueless, and I am scared out of my bejesus. Right? Because all the patients are sickly and dying. We know this. I'm a knuckle dragger. They think like I know what the hell I'm doing. So that night now the attendee walks out. She's like, yeah, it was a rough night. I'm gonna go lay down in the call room. If you need something, call me. And then she looks over and she goes, but if you call me, I'm gonna take this as a sign of weakness, right? So I'm like, there's no way I'm calling this woman tonight. It's like, not gonna happen. And then all night long, all the alarms are going off on all the patients and they're all trying to die. And the ICU nurses save my bacon, right? They're like, hey, you might wanna consider this. Hey, you might wanna do this, you might wanna do that. So I talk trash about the nurses, but if you take care of your nurses will take care of you. And if you don't, oh, they'll screw you. They'll get you, right? Because they have that capability, nurses, right? So be kind to your nurses. All right, check on learning. You have a patient, let's say 65-year-old male. He came in with, fever, chills, weight loss, night sweats. What does that sound like in this class? Woo. We're in the ballpark. I like it. All right. Nobody can ever see when I write anything over here, so just listen. His hemoglobin is 9. What does that tell you? He's anemic. His platelets, let's say 70,000. What does that tell you? His white count is 65,000. What are we dealing with? What are you thinking at this stage? What are you thinking? Good. If you're not thinking right now, this test is going to get ugly.
Bone marrow cancer.
Like bone marrow cancer. So you're thinking he has what? What do you think this patient has? Just some sort of. Okay, so you said a lymphoma. All right, and what else? 65. Something like that. Has anybody started to think about leukemia? Right? This dude's white count is off the charts. Right? Not a normal white count. You all know that, right? Right? So you have to start thinking leukemia if you get something like that. And what are your flavors of leukemia? So what do you need to know what type of leukemia you're dealing with here? Blasts, all right, so he has a lot of blasts. He got greater than 20% blasts. What do you want to know about the blasts? He's got blasts. So now what? So that should have narrowed your differential, right? Because blasts show up in what type of leukemias? Acute. So now you know you're dealing with an acute leukemia. Everybody tracking so far? Please, because this is right. This is your personal check right now on knowledge, right? If you're not tracking this, you probably need to come find me. So again, you got this patient. You got it, older dude, with all your cancer symptoms. Anemic, you got some low platelets, you got that high white count. So you think, hey, I'm dealing with a leukemia. You're not sure what type of leukemia at that stage, but you're betting on leukemia. You get your slide back, you got a bunch of blasts. So now you narrow your differential to an acute process, right? Blast equals immature cells equals acute. So how do you know what type of leukemia it is? You gotta know what type of blast you're dealing with. Am I dealing with myeloblasts? If I'm dealing with myeloblasts, what's my diagnosis? AML. If I have lymphoblasts on there, what's my diagnosis? All right. Why is he anemic? I'm crowding out the bone marrow, so I'm producing less RBCs. Right? If you can get to that in your mind, that says, hey, you're tracking along. If that's not making sense to you, then, right, come find me. Take a step back. There's going to be questions like that. So, yes, there's some first order questions on the test. So don't tell me I didn't tell you that, right? I don't know how that's a thing. Like, I'm sorry we failed your test, but you know they gave me first order questions. Everybody kind of there-ish? If not, kind of figure out where you are. All right. We got a lot of stuff to get through today. And we're going to get through all the emergencies. If I start to just talk and ramble, and it's a time for a break today, yell at me, so. All right. Our usual objectives. Emergencies. Yes, life-threatening stuff. Simple. Associated with cancer. So, we talk about it manifesting locally from an obstructive process. All right, is this cancer pushing on something? Is it pushing on a critical structure that's causing problems, causing obstruction, causing pressure? You see the example for that when we talk about like superior vena cava syndrome. And then is it systemic? Are there complications from metabolic processes, such as even like tumor lysis? Occurs iatrogenically. What does that mean? It means we cause it. Secondary to our treatment, we institute, cause something, we trigger something, again, as in tumor lysis syndrome, where we treat a cancer, and then we got the complications from all this cell lysing. All right. So, first thing we're going to talk about, malignancy associated hypercalcemia. So if we're talking about hypercalcemia, you need to know what normal calcium is to begin with. What's your normal range? 8.5 to 10.5, right? So hey, start with what does normal look like? And in this case, we're talking about elevated calcium levels due to increased bone resorption by tumor cells. Yesterday, we talked about multiple myeloma. We talked about CRAB and that elevated hypercalcemia patient, right? What was going on there? Why was that? Where was the calcium coming from? From bone, right? The bone resorption. Right? The plasma cells going into the bone. All right. The mechanisms. We talk about parathyroid hormone-related protein, right? Which is associated with humoral hypercalcemia, which accounts for 80% of these hypercalcemia cases. Bone destruction, kind of we talked about multiple myeloma yesterday, and vitamin D secretion. What's the role of vitamin D and calcium in metabolism? Right. Vitamin D, right, facilitates the absorption of calcium through the GI tract. You guys all know this stuff. I'm impressed with this class. All right, malignancy, here we go. So what's the presentation, right? And we talked about some of this stuff with hypercalcemia the other day too. We get neuropsychiatric disturbances, GI symptoms. What's the kind of GI symptoms we talked about with hypercalcemia? Nausea, constipation, sure, abdominal pain, renal dysfunction, musculoskeletal symptoms, and cardiovascular symptoms. Right? When do we start to see the symptoms? Again, keeping in mind what your normal range is. So less than 12, asymptomatic, maybe a little fatigue, maybe a little anorexia. Start getting up there, 12 to 14, you start seeing some of the other symptoms. Nausea, constipation, polyuria. Greater than 14 is where you start to see the neuropsychiatric symptoms and the arrhythmias. You guys hit this one out of the park, your stone bones, something like that. Some version of that. Stones, your kidney stones, yes, bones, your abdominal bones, mental bones, however you want to memorize that. But again, that's your hypercalcemia patients. Diagnostic. Talking about calcium. So serum calcium corrected for albumin or ionized calcium are the key tests. PTH, and then that parathyroid hormone related protein we talked about, and then potential imaging, right? Even like in the case of multiple myeloma, we talked about the importance of imaging to go looking for lytic lesions. All right, somebody talk to me about serum calcium versus ionized calcium.
Serum calcium is higher. Serum calcium we have to worry about the amount of protein.
I have no idea what you just said, but okay. So when you order a lab test, you order your Campana, you get your calcium. Depending on your laboratory, right, and this is where you guys got to pay attention and figure out what it is you're ordering and what it is you're getting. So some of this calcium in the body is bound to albumin. The stuff that's bound to albumin is not active. If you just get a regular serum calcium, you're getting the calcium that's free, or ionized calcium, plus what's bound. What's bound doesn't really matter because it's not active. Some labs and some hospitals just run ionized calcium, which is what you want to get. So that's that free calcium. There's a correction if the albumin level is low, if what you started with was a serum calcium. So if you have a serum calcium and your albumin level is low, then you need to correct it. And we'll talk about that in a second. All right. Serum, yeah, I was right, we are gonna talk about it. Good. All right, serum calcium, right? So again, the corrected versus ionized. If the patient has a low albumin, there's your reference range for albumin, so less than 3.5, then you need to do that Yahoo calculation right there. Take your measured calcium, subtract your albumin, and add 4. So again, I hate inpatient medicine and I hate rounded, but always pay attention to what lab of body are you actually getting. Is this an ionized calcium? Is this a regular serum calcium? Right? Did the person before you order the same test? Are you ordering the same test? Are you comparing apples to apples if you're looking back at somebody's chart? Right? Especially if what you're trending is their calcium levels. So just be mindful of that. Yeah. So I gave you one formula, which is get to the, so this formula, all right, this side of the room, I want you to use this formula for problems that coming up. This side, I'm going to show you another formula, and let's see if we get the same answer. All right, this side of the room, here, I want you to use this formula. Everybody good with the formula for, this is another formula for corrected calcium. For this question here.
Can you go back one second?
100%. Let me know when you're good. Everybody good? Ish? Good? Good, moving on. All right. What do you guys get over here? What do you guys get over here? Yeah. So 12.6, 12.12, right? So is 12.6 clinically significant versus a 12.2? In the big scheme of things, probably not, right? However, if this is a patient and you're really worried about their calcium levels and you're trending, could make a difference how you can manage it. So that initial formula that I showed you guys is kind of like, hey, this is the quick, easy method. This is the more accurate method if you had to do it. And if you like have one of those, I don't know, those little app calculator crap, or what is it, like MedCalc or whatever, yeah, they use this formula actually. But no, I'm not gonna like put you on the spot on the test and like make you figure the crap out, right? But just understand that there's two different formulas out there. Again, make sure what you're doing, like if you're trending somebody, and like make sure like everybody on the team is doing stuff the same way, right? Because you can create confusion. Right? Confusion for your patients never end well. All right, moving on. Diagnostic test. So how do we approach the hypercalcemic patients? All right. So, yep. So we want to confirm, right? You got this abnormal test. Before I start like giving calcium or treating calcium or whatever, I need to confirm it, right? So once you're satisfied, yep, it's for real. And if you had a pure serum calcium, you did your corrections, and you know what you're dealing with. Next what? Measure the PTH, parathyroid hormone. If it's elevated, that suggests that that patient's problem is primary hyperparathyroidism. So start with that PTH. If the PTH is low or normal, then you're going to measure the parathyroid protein. All right. Humoral hypercalcemia. Excessive parathyroid hormone-related protein. So these tumor cells, kind of when we talk about the paraneoplastic syndrome all the way back to day one, right? These tumor cells are kicking out this protein that the body sees the same way it sees PTH. looks like PTH to the body. And what does the body do with PTH? What does it kick in? Right? PTH kicks in when your calcium levels are low and the body's trying to increase your calcium. Right? So this is what's happening. The body, the tumor cells, is producing this hormone that looks like PTH to the body, and it's having that same mechanism. Most common cause, yes, right? Same as PTH. Mimics the actions of PTH. Promotes the kidney to promote calcium retention. Right? So this is like normal PTH, right? Low concentration of calcium, what does it do? Right? Starts to get some calcium out of the bone, tells the kidney decrease the loss of calcium, so it's hanging on to calcium, tells the GI tract to increase absorption of calcium. So the body's normal response to PTH is, hey, let me hang on to calcium, let me put more calcium in the system. So when those tumor cells is producing that hormone that the body thinks is PTH, right? Now the body is producing more, retaining more calcium, and thus you get hypercalcemic. Everybody tracking? All right. Next. Is it just a local osteolytic lesions, like in multiple myeloma? Suspected patients with extensive skeletal mets. So if they have a lot of mets to the bone, and the bone starts to break down and they develop these osteolytic lesions, now you're reaching calcium right into the serum. So they get hypercalcemic. Yeah, so again, right, how are you gonna skin that cat, right? You're gonna measure your PTH to start, and depending on if PTH is high or low, is to tell you whether or not you need to get the parathyroid protein. And then think of what calcium does. Right? Not good when I start messing with the heart. Shorten that QT interval. Set you up for arrhythmias and badness. Management. First line treatment for hypercalcemia. IV fluids. Hydrate, hydrate, hydrate. Solution to pollution is dilution, sort of thing, right? You gotta hydrate. And then the bisphosphonates, which you guys are all very much familiar with because you told me so. Additional measures, glucocorticoids for lymphoma or vitamin D cases, sure, and then dialysis if it's really bad. Right. The initial therapy, fluids and bisphosphonates. Any questions on humoral hypercalcemia? All right, spinal cord compression. So compression of the spinal cord by the tumor, right? Is the tumor sitting there, or are there mets that's sitting there? Right? Common cancers associated with lung cancer, breast cancer, prostate cancer. Those are the big ones. So direct tumor invasion or vertebral collapse from lytic lesions. Get compression on the spinal cord. No bueno. You can think of all the symptoms that can happen. So what type of symptoms do you, before we move on, what is this patient presented with? Back pain.
Paralysis.
Yeah, maybe some radicular symptoms, right? Alright. Key symptoms, back pain, localized or radicular, pain worse at night, pain with that sneeze and coughing, so it increased the pressure. Neurological deficits, sensory weakness, bowel bladder dysfunction. You guys did ER already? You're in ER now. You guys talk about cardiac equina? Yeah? Or you did cardiac, right? Was your cardiac equina patient present like? Shadow anesthesia, what else? Incontinence. Or sometimes what you don't think about is that the opposite of incontinence, the retention. Bowel bladder dysfunction, weakness, sensory, those neurological deficits, right? And then late signs paralysis. Persistent compression can be irreversible. If this goes on long enough, it might be permanent damage. And then what do we do? Emergent MRI. So hey, if you're seeing a patient like this, and this is even on your differential in your mind, right, and this is, and you're not in an ER setting, maybe you are in an ER setting, but certainly in clinic, this is a call to the radiologist, right? You're just gonna send this patient down and hope, and they schedule, hey, come back in 2 weeks for your MRI. This is a conversation, you to the radiology team, hey, this is what I'm worried about, I'm sending this patient, I need an emergent MRI. Labs, right, what are the labs we always get on all our patients? CBCs, cancer, tumor markers, our 10 panel, all the data stuff. So hey, key here, MRI, right? And when you get an MRI, like my pain is around L4, L5, I just need an MRI of the lumbar region. True? No, you need a full spine, right? Because do they have lesions elsewhere in the spine? And they're just presented with pain at L4, L5, but you go all the way up and they're all jacked up. Right? So it's full spine MRI. And again, I'm not a radiologist, but that don't look good. Right? That don't look good. Start pushing on your spinal cord, right here. And you get all those neurological symptoms we talked about. Again, not good. All right, management. High dose dexamethasone for known cancer patients. So this is a patient who walked in the door and at a baseline you knew this patient had cancer. If this patient does not have a confirmed diagnosis of cancer, do not give corticosteroids. Part of it is they believe that the steroids could induce a response and then the pathology result gets jacked up and then you get a delay in making the diagnosis. It affects your path results. So known cancer patient, steroids. And ultimately, right, what's going to be the treatment for these patients? You got something pushing on your spine, what are you going to do? You're going to need surgery, right? Definitive treatment, surgical decompression. And again, just the idea that if there's a delay in diagnosing and a delay in treatment, right, it could have permanent neurological problems. Hey, I just threw this in here for you, I'll just take 2 seconds. So you're gonna see back pain patients all day long, right? Knees, back, shoulders. Do you get an x-ray? Do you image every patient that walks in your door has a back pain? You don't, right? And again, patients love imaging because it makes them feel better, right? Now, I need an x-ray, or worse, right? Nowadays, everybody walks in and says, I need an MRI, right? Because, I don't know, LeBron James got an MRI when he twisted his knee, so I should get an MRI too, right? And that's the mindset, and you're gonna have to have those conversations with your patient. Yeah. Right? Yes, sir, Roger, I got it. But right now, I don't think you need an MRI. Right? How do you have that conversation and not just tick your patient off? Because they walk in there with the expectation is they're getting an MRI. Right? Do you jump to an MRI, everybody with a knee pain, a back pain? Right? Again, hey, so in general, non-traumatic patients, no imaging, right? Do not do imaging for low back pain within the first 6 weeks. In general, right? There's always exceptions to everything, but these are the red flags that would, hey, I better image. Right? Fever, trauma, obviously, right? Serious underlying medical condition, meaning cancer. Right? If this is a cancer patient, my threshold for go looking for badness is pretty low. Yeah, just kind of keep that in the back of your mind, right? who are you gonna image or not? Because you're gonna have to make this call all the time, and then you're gonna have to explain it to your patients why or why not you're gonna get an X-ray, why or why not, no, you can't get an MRI. Right? And people get real testy when you tell them they can't get stuff. All right, moving on. Febrile neutropenia. What does that sound like to you? Fever. Fever associated with what? Infection. Infection associated with what? Low white counts. Low neutropenia. I don't have the neutrophils to fight the infection. Right? So hey, fever greater than 101, ANC count less than 1500. So the absolute neutrophil count. I'll show you how to calculate that in a second. Neutropenic patients unable to mount a robust response. Fever is often the only sign of infection. Cause is, hey, yeah. So again, we go back to no treatment is benign, right? We treat these cancer patients with chemo. Chemo knocks out their bone marrow. They get neutropenic, and then what? Now they got a secondary infection, right? So again, no treatment is benign. This is how you calculate your absolute neutrophil count. Here's the calculation. Normal range, 1.5 to 8, got it. Mild, moderate, severe, right? Depending on just how low that ANC goes. But by definition, less than 1500, right? Less than 1500, and that fever greater than 101, you deal with a neutropenic fever. And sure. You guys got all that? Bingo. Good. All right. Okay. So again, during chemo, right, the ANC will decrease, and this is just kind of showing that nadir picture when it's at those points. So they get chemo, right? Blood count decrease 7 to 12 days after chemo, standard expectation. Right in that window when it's at its lowest, with the highest risk for infection. Then they get to, all right, they get past this, they recover, their white count comes up a little bit, and what do we do with them? And then we hit them with some more chemo, right? And that vicious cycle during their treatment. But the nadir, when you hear people talk about the nadir, it's when it's at its lowest count. And in your mind, that means they're at the greatest risk for infection. Again, sometimes fever is the only symptom. And then localized. Do they have something else going on that's going to steer you towards that? Where's that nidus of infection? Right? Do they have a cough? Oh, maybe it's in their chest. Maybe they have a pneumonia. Dysuria. Maybe they have a UTI. Maybe it's some abdominal process. Right? But again, sometimes they just show up with a fever, and then you're like, oh boy. Yeah. Fever in cancer patients. So, hey, this is just a reminder, right? If you're having your conversation, you saw your patient in clinic, you know, before you discharge, you give them all your patient education stuff, and then you tell them, hey, if something gets worse, if you start running a fever, yada yada yada, that's a visit, that's a trip to the ER. And you have to have those conversations with your patients, because again, some people kind of ignore stuff and just sit on stuff, right? And again, cancer can be, depending on where this patient is in the scheme of things, these patients probably have come to terms with their cancer because they're probably getting chemo. I had a lady who PCS to me in Florida. So at her old duty station, before she left, she got diagnosed with a brain tumor, right? PCSs, takes a vacation to the Philippines, right? Doesn't seek care because in her mind, like, you know, again, you know, stages of grief. Right? She had to come to grips with the fact that she got diagnosed with cancer. Right? So now she's a couple months behind the power curve, and now I'm like trying to put consoles in the system to get this lady seen. Because now she's coming to grips with the fact that she actually has like a brain tumor. Going to the Philippines did not cure her brain tumor. Have the conversation with your patients, right? And then make sure you document in your chart that you had the conversation with your patients. When your patient don't do it, and they say, hey, the doc never told me, you'll say, no, here's the note. I had this talk with the patient. All right. History physical, targeted. You want to find the source of infection. Again, a lot of times the only thing they're presenting with is the fever. But if they're giving you a clue, right, and if they're not giving you a clue, then you need to go look it. And you gotta look everywhere because you wanna find the source of the infection. Right? So you do a thorough exam. If they have any catheters, anything indwelling, that's just badness, right? Routine DREs, don't do them. Cancer patients. Right? Yeah, you run a risk of just seeding that whole person with whatever bacteria they have in their colon. So you really try to avoid those in cancer patients. Just stay away from that. Majority of patients will not have a documented infection. Yeah, all right. Gram positives, or, got it. Hey, so this patient is a full workup, right? These are scary patients. So you're gonna get your CBC. You're gonna get your chem panel. What's lactate telling you? Anaerobic. So sepsis, right? So do you use this all the time to, hey, kind of to help us evaluate if this is a sepsis patient or not? Right? Do they have an elevated lactate? And then you're gonna get all your cultures. You're gonna culture everything because again, you want to know where's that infection coming from. Chest X-ray may not show infiltrates. They're neutropenic. A lot of times those infiltrates that you see on a chest X-ray is that inflammatory response, those white cells responding to whatever that bacteria or whatever is going on. If they don't have a bunch of white cells, you may not get a robust, right? So again, part of what you do when you're ordering your chest X-ray on these patients, you're telling a story to the guy receiving it, right? So the radiologist should be able to read it and know what you're looking for, right? Because he might look a little bit harder in this patient, might look a little bit different, right? Might cause him to interpret things a little bit differently. So it's always important that you get a good story, right? Let the radiologist know what you're worried about, so they can take a look. And then CT, that's enterocolitis, again, good. Initial therapy, we're dealing with a neutropenic fever, we're dealing with an infectious process, so our treatment is, right? Pick your gorillacillin of choice, I don't care. I like Zosyn, we use Zosyn a lot in the ER, but you want something broad spectrum, within an hour. So these are the patients you gotta hit them fast, right? Within an hour, you wanna get some broad spectrum antibiotics on board with these patients. Continue antibiotics until, right, you get a bump in their ANC and afebrile for at least 48 hours. If they're not responding to the antibiotics, right, up to 4 to 7 days later on, then what do you add? An antifungal. Amphotericin, whatever it is, pick an antifungal, right? But they're not responding, because if that we don't know what's causing it still, right? Now we got to cast a broader net. So now we throw some antifungals on there. And then disposition. You're seeing this patient in an ER. Right? Hey, are you good to go home? You feel comfortable sending this patient home? Right? Do they need to get admitted? Right? And again, a lot's going to depend on this. How did your patient respond to that initial dose of antibiotics? What are their vital signs? And then what's their ability to take care of themselves? And do they have people at home to take care of them? Or is this an old 75-year-old dude who lives by himself and nobody's going to check on him and wake up or not wake up 2 days later, right? And nobody was there. So kind of figure out which patient is safe to go home versus which ones are not. All right. Neutropenic fever with a clinical focus of infection. So that's nice. Nice in the sense of, hey, I know what the source is. So an example of this would be a patient went to their primary care doc for urinary tract symptoms, UTI symptoms. They got a UA, they got a culture. You're seeing this patient in the ER like a day later, you have the culture result. You know what the problem set was. This patient had a UTI, it was E. coli. So now you can target your treatment towards that, right? Versus in the second case, hey, they come in with that neutropenic fever, they're symptomatic, but I don't know what the pathogen is. So they have a cough, I might be thinking it's a pneumonia, but I haven't had the time to culture it to tell you exactly what that bug is. See the difference? Right? One, I can target my therapy towards that pathogen. One, I'm kind of taking a guess, right? And then versus here, unexplained, right? These are just, they're febrile, and you got no idea. And these are the ones that you really have to cast a wide net on. And a good old fever of unknown etiology diagnosis that we throw in their charts, right? They're febrile, we're not sure, right? What's the source? All right, any questions on febrile neutropenia? All right. Because I'm gonna have questions for you on febrile neutropenia. All right. Superior vena cava syndrome. It's fairly straightforward. All right. Obstruction of the superior vena cava, so by malignancy or a thrombus. So you got cancer, you got a tumor sitting somewhere that's blocking off your superior vena cava. Start thinking about the anatomy, right? What flows? Where does that go? What kind of symptoms gonna have if I have a blockage in my superior vena cava? And then talking about malignancy, could be a thrombus. Talk about cancer as a what? What type of state? Hypercoagulable state, right? Increased risk, throat clots. And some of these patients do have indwelling catheters, again, increase their risk for clots. You see the cancers here, right? So lung cancer by far the most common to cause this. But lymphomas or just mets to that region could cause this. Presentation. All right. Superior vena cava, obstructed, blood backs up, right? Up into the face. So some facial swelling. Neck, upper extremity, headaches, dizziness, distended neck veins. Bending over or lying down attenuates, it makes it worse. If you're suspecting this, how are you going to make your diagnosis? I got something, I think, sitting on their superior vena cava. I need to take a look. How am I going to go about doing that? Chest CT. Chest CT. Depending on where you are and the radiologist, some people are like, oh no, you gotta get stuck with an x-ray. Like, sure. You're the radiologist. If you're gonna make me order it, I'm gonna order it. Right? The x-ray is gonna show something and they're gonna say, okay, now let's get the CT. You'll be like, I told you so. Right? Here we go, this imaging wise, right? You guys, Pancoast tumors, do you guys talk about that at all? What's a Pancoast tumor? Oh, right, so the apex of the lung, so those are classic that kind of cause it, right? Just by the location. You got this sitting on somewhere in here, causing some obstruction, everything starts backing up. Everything starts backing up, right? Here's an x-ray, right? Again, you get that, you're like, oh crap. All right, patient's having a bad day. And then you're probably gonna order your CT. All right, and there's some CT imaging. Initial therapy. So you're seeing this patient in your ER. What can you do immediately to kind of alleviate some of the symptoms? Elevate the bed. Right? Steroids, diuretics for symptomatic relief. Sure. Definitive, you gotta treat that tumor. You gotta treat whatever is sitting there blocking it. So ultimately, at the end of the day, chemo radiation. Stenting for severe obstruction, sure. If the vena cava is collapsing down, then hey, do they need to go in and put in a stent to maintain the patency of that vessel? Everybody good? Am I going way too fast? No?
Good, sir.
Good? All right, I like it. All right. And then we talked about thrombus, right? So do they need anticoagulation? Do they need a thrombolysis to go clearing it out? And then prognosis, sure. What's the cause? Right, and how do they respond to therapy? All right. Superior vena cava syndrome, pretty straightforward. I got some tumor, some mass, something blocking my superior vena cava. All right. Everybody good? Stop lying to me. All right. Tumor lysis syndrome. So a couple of the disease processes mentioned tumor lysis syndrome before. I said, all right, eventually we're going to get to it. So now we get into it. So tumor cells, right? Rapid tumor cell lysis, yes, leading to intracellular contents in the bloodstream, sure, occurs with, so hey, malignancies with high proliferative rate, large tumor burdens, right? These are the ones you see most often. And we talk about stuff being iatrogenic, we caused it, following initiation of chemo or radiation. So it can happen in any cancer. I'll just say that, right? It can happen in any, but it's more common in these, right? These high proliferative ones. But it can happen with any disease, any of the malignancies we talked about. Most commonly though, ALL and Burkitt's. So what we're talking about here is we treat these patients, chemo, radiation, causes and our goal there is to do what? Kind of kill off the cancer cells, right? And we do, we're successful. We kill a bunch of cancer cells at the same time, and now they release all their contents into the bloodstream, right? So you start thinking about the intracellular components of just normal cells. What's on the inside of cells? Potassium, that's one. Right? What else? Alright. Yeah, so you got the potassium, hyperkalemia, phosphate, hyperphosphatemia, hyperuricemia, uric acid, and in this case, you get hypocalcemia. Why hypocalcemia? It's inverse to phosphorus, right? It's inverse to phosphorus. So I'm spilling all this phosphorus out, so then the body kicks out all the calcium. All right. And this is kind of talks through what we just mentioned, right? So you get this massive release. You lyse all these tumor cells, and now everything spills out into the system. Potassium. What's the risk of hyperkalemia? Arrhythmias, right? That's what we're talking about, right? Just the arrhythmias. So you're gonna die from. Yeah, and then kind of talking through the nucleic acids, right? How did I get to my hyperuricemia? So these purines, got it. Uric acid, right? So now I got it. And then the phosphorus we talked about, and then the secondary hypocalcemia, tumor lysis. So how does it present? Muscle cramps, tetany, that's from the low calcium. Arrhythmias, no good. Kidneys, right? The kidneys take a hit. So, hey, labs. I'm gonna get my chem panel. I'm gonna make sure I can monitor all this stuff. I'm gonna pay close attention to my kidney function. Everybody good? All right. I don't think you guys have this slide. But hey, this is a Cairo bishop. All right, so I mentioned it here. It's just a way to risk stratify based on, hey, how their labs are presented. And we can say, oh yeah, this is how bad they are versus not. So again, hey, hyperkalemia, there's your normal values, right? You have to know what normal is to know what abnormal looks like. And then arrhythmias is the big scare, right? Nearly half patient, so 6.5, still not manifest EKG changes. Bradycardia, right? What's the classic? The BT waves, right? There you go, fib, arrest, kidneys take a hit. And then the hyperphosphatemia presents with some of those GI symptoms, the nausea, vomiting, and in worst case, seizures. So the good thing for you here, right, a lot of this is, again, we cause it, so we know that, hey, at baseline, we know this patient has cancer. We know that it has received chemo, right, within the last whatever, right? So if they start presented with these symptoms, right, that needs to be on your differential. Management, aggressive hydration. before, during, and after. What's the saying? The treatment for pollution is dilution kind of thing, right? Aggressive hydration. Because hey, you're gonna hit them with the chemo because you need to kill the cancer, you need to treat the cancer, and a byproduct of that is they're gonna have some lysis. So if I hydrate them ahead of time, if I can get ahead of it instead of trying to treat from behind, I'm much better off. And then allopurinol, you guys know, right? Treats what? Gout, right? Which is the uric acid piece, potassium phosphate binders. And if the calcium gets low enough, do we need to give them crowns? Do we need to replete their calcium? Right. Again, here's your treatment. Fluids, allopurinol or asbesicase. Watch for the electrolyte abnormalities. Severe case, like your kidneys took a hit, they need dialysis. And this is just kind of talking through the uric acid piece on this more than anything else here, right? The allopurinol blocks that enzyme. So if I can't go from here to uric acid, that's how I stop my production of my uric acid. If that's failing, not working, they switch to the rasducicase, which doesn't stop the uric acid, but it converts it to this, which is a lot easier for the kidneys to get rid of than the actual uric acid. Everybody good? All right, hypercalcemia, what do we expect to see? Here's your treatment. Nice charts. Spinal cord compression, how did it present? I get spinal cord compression, back pain, right? Neurological, who gets steroids versus who doesn't? I believe you. All right, febrile neutropenia, right? Again, easy, it's infectious, I'm gonna hit with some broad spectrum antibiotics. Superior vena cava syndrome, elevate the head of the bed, sure, right? Ultimately, you need to target whatever is causing it. Need more radiation. And then your TLS, so that's your patient, you really have to watch their chem profile, right? You gotta see what's going on. What's going on with their potassium, what's going on with their uric acid, what's going on with their kidneys, their kidneys taking a substantial hit, right? You'd have an acute kidney injury. How do you get ahead of this? How do you get ahead of TLS? Hydration. Right. Let's take 10 minutes and come on back and we'll knock out the last couple slides. So after talking to some of your shipmates during the break, I realized I had to go back and rewrite the test. So I had a bunch of questions about calculations on there, right? And I felt like I was insulting your intelligence by including calculation questions. I'm going to take them all off. Right? So don't worry about knowing any calculations. Trying to know the concepts.
Harder question.
All right. Okay, so cancer and pain management. So we're going to talk about this a little bit, but again, just kind of keep in mind, right? Cancer can be a scary diagnosis for a lot of people. Have some empathy on all your patients, and certainly cancer patients are worthy of maybe a little extra empathy. Because what we're going to put them through, right, being the medical profession for their cancer can be challenging, to say the least. There's a lot of pain associated. Sometimes the pain is from the cancer itself. Sometimes the pain is from the treatment. Sometimes it's from the processes and the tests that we got to do. Hey, I'm sorry, but we need to do a bone marrow on you. That can be a problem, right? They have a big empyema or something going on in their chest cavity. I got to do a chest tube on you, right? So we can put them through some uncomfortable stuff. So understand that. Two, we're going to talk about opioids a little bit here. So, you know, we've kind of, as a society, gone through the opioid crisis, and as providers, we've had to look at how we do business. There's days where people would just dole out ungodly amounts of opioids. Right? When I was in the teams, I'd send dudes to get orthopedic surgery, and they'd come back with like 300 Vicodin. I'm like, holy crap, right? And then now my teammate now is addicted, and I'm the one that's got to go to like the CO and have this conversation. Right, well, we got to send this guy treatment. Right? So again, you know, kind of think about it, be judicious, but don't be stingy, right, with the medications also, when used appropriately. But we don't want to set people up for failure either. All right. You do it.
Are we able, as military, I know civilian side can, are we able to prescribe marijuana for cancer patients?
So right now, that would be a no.
Even if they were like retirees or anything like
Yeah,
that?
I don't think there is a line. Now, there is one or two meds that's out there that I think that they allow. Right. But in general, that's a no-go for us. Yeah, I didn't think there was like a couple of derivatives of like the THC stuff that they're bringing online. And it's becoming like a thing. And the DOD and all different state rules, and the DOD is gonna have to figure out how they're gonna attack that, because that's creating its own problems there. All right, cancer, significant problem, yes, makes sense, right? Impact their overall well-being, impact their quality of life. If you're in pain all the time, your quality of life might not be great. Types of cancer pain, sure, acute, got it, chronic, yep, right? Is it pain from somatic or visceral tissue versus neuropathic pain? What's the classic neuropathic pain type? What do you say it sounds like, feels like? That sharp shooting, right, nerve pain. Kind of what we mentioned, pain caused by the cancer itself, or is it the cancer treatment? Or is it a procedure, something that we are doing that's causing further pain, right? It's 50%, sure, probably more than that, right? Decreased quality of life, physical function, and emotional well-being. Often undertreated, yes. So now, like, we've gotten a little bit gun-shy about opioids. Again, these are the patients that I'd probably be a little bit more lenient about. And to be honest with you, these are the patients who, when they get to a certain stage, right, part of your healthcare team is pain management specialists, right? All right. Got it, neuropathic, nociceptive pain, sure. What is that? Funny. Damage nerve, yes, chemo, burning, shooting, tingling pain, got it. All right. So tumor-related pain, right, there's these bone mets. Right, that can be very painful. We talk about a lot of these mets and these lytic lesions. Treatment-related pain, sure, chemo, whatever, right, radiation. And then post-surgical, again, no treatment denied, right? Do they have complications? Do they have residual pain from whatever procedure they went through? Acute pain syndromes, sure. So just a bunch of diagnostic interventions. Lumbar punctures, not fun, right? Endoscopy, biopsies, right? Bone marrow biopsies, these are regular occurrences for cancer patients. Acute pain syndrome, yeah, fluorodesis, right? They need to put in a chest tube. Abdominal paracentesis. Wait till you get to draw like a couple liters of fluid out of somebody's belly, right? Acute pain syndromes, cancer, sure. Herpes zoster. They say that like that hurts. Right? You get people talk about that neuropathic pain, right? Herpes zoster kind of classic for it. All right, and just some more, right? Chemo-induced arthralgias, you name it, right? So there's plenty of reasons for your cancer patients to be in pain. Assessment, standardized pain assessment tools. Right? So if this is a patient you're seeing all the time, whatever tool you're using, be consistent. Right? Hey, if you change stuff up, then you kind of, where are you really in the pain, right? And cultural linguistic background. Some societies are more like, tend to be more stoic about stuff and don't want to complain. They don't want to admit to the pain, and they're just, yeah, sure, I'm fine, I'm good, right? Think about who you're talking to. And then obviously language is a barrier that you need to do something about that. Psychological, social factors, yes. History, you guys don't know this. Onset, duration, the usual stuff. Focused exam, right? What's going on with this patient? And then your usual evaluation type stuff. Got it. All right. Your modified pain, alter, block, sure. You gotta do something. All right, so who? Here's the kind of analgesic ladder. Here's sort of that stepwise. So again, start off simple. Non-opioids, some adjunct therapy, opioids, sure, and then an escalation, right? You don't necessarily need to come out of the box swinging. If they're able to tolerate and manage your pain with something simple, go simple. Go your NSAIDs, go your whatever. If opioids are needed, then hey, do I need to start introducing opioids? The old fentanyl up here. Oof. Tramadol. You guys talking about tramadol? Ultram, terrible medication, avoided at all costs. So like over the years, my practice pattern, I try to stay away, especially from elderly patients. So tramadol is somewhere between like a little bit of a narcotic versus like an antidepressant, some kind of medication in between, right? There's a lot of side effects associated with tramadol, especially in elderly patients. Right? A lot of elderly won't tolerate tramadol well, so be mindful. And just another approach, right? So again, kind of stepwise, and you can kind of see how they go here. So it started fairly simple. Tylenol, some NSAIDs, steroids, right? Adding some of those other meds to it, some steroids potentially. And now it's starting to stepwise up. Hey, throw some codeine in there, some hydrocodone. And then sort of now your morphine and so forth, right? So stepwise progression. Don't be cheap on the pain meds. And then look for other ways to treat patients' pain. What are some other ways we can help them with pain outside of medication? Nerve block? What are the modalities for pain? Oh, you guys are all fired. Like you guys, meds is not always the answer to everything. What else can you do for your patients? So sometimes physical therapy can help with pain, right? There's other hey, go get a good massage, acupuncture, right? There's other modalities. It's not always meds. Man, you guys are killing me. All right, mild pain, no non-opioids we talked about. Sort of that stepwise, moderate, some weaker opioids, and then just cycling up, right? Here we go. Yep, short acting for breakthrough. Long acting is more to baseline control. And like we talked about, everything has side effects, right? Put a patient on a bunch of narcotics, what else might you want to give them? Stool softeners. Am I setting this patient up to be constipated and miserable on top of it, right? And then adjuvant therapies, neuropathic pain, right? Gabapentin. We use gabapentin a lot for neuropathic pain, right? Amitriptyline. What's amitriptyline? TCA, which is like, try to stay away from TCAs, but, right, in the right patient at the right time. Nerve blocks, epidural injections, rehab, physical therapy, occupational therapy, cognitive behavioral therapy, acupuncture, massage, mindfulness, meditations. There's all these other modalities. Right? It's not one size fits all, but think outside the box a little bit, right? And these patients should really have like a comprehensive team taking care of them. Right? Breakthrough pain, yep, sudden transient worse, got it. Opioid tolerance, right? I become intolerant. I need to do more and more of my escalated doses. And you'll see that happen to these patients who are on these meds over time. End of life pain management. I try not to be involved in this stuff. So by then, you have to think about where this patient is in terms of care. Have they moved on? Are they in a home someplace? Where are they at? But these are real conversations that you may have to have with your patients, but it should be a comprehensive team when you kind of get to that stage. Don't take that on yourself, right? If you're not comfortable with stuff like that. But understand somewhere, somebody's having these conversations with that patient. Bone pain, we talked about neuropathic pain, a couple of choices. Cool. Team members, yeah, palliative care, nursing, again, mental health professionals. Cancer can be a very, very taxing thing for patients and their families. So are you setting them up for success? Sometimes you get the social worker involved, right? You get all these other people involved. And you have the ability to consult, right, to pain management. You have the ability to consult on to physical therapy, occupational therapy, to the social worker who's in your facility, the social worker. Challenges, sure, fear of addiction. Again, sometimes having that conversation with that patient early on. Because again, you have some people who are like, I don't want opioids. Right? And then the pain gets worse and worse, right? You have to have that talk. Polypharmacy, my favorite word in the English language. Right? Multiple medications. Again, we talked about the increased risk, right? These patients are on some sort of, cancer treatment stuff. And then they have whatever problems that they started at their baseline, their diabetes and their hypertension, and they're on meds for that. Right? And now you're storing some more meds on top of their other meds. Polypharmacy, right? Setting patients up, so be mindful. Sure, the WHO ladder, we talked about opioids, non-opioids, right? Individualized pain assessment and management, right? This is not a one-size-fits-all type of scenario. This is you and your patient sitting down and figure out what their needs are and try to get to that, whatever that is. Because right for that dude might not look like right for that dude. Sure, categories of treatment for pain, yep. All the stuff we talk about. Implantables, you guys familiar with those? Sometimes they put like nerve stimulators, right? All right. Pain management. Be smart, be judicious, stepwise approach. Good? You gotta say that till the test is in front of you. All right. Since I don't know what to do with this class because apparently you don't like sports. Apparently you don't like sunshine or puppies or anything nice. So you can't figure this class out. You love dogs? All right, hey, so Spanish basketball team Paralympics, Sydney Games, right? So again, this team here, the dream team, crushing hearts and souls, beating up opponents by 30 points. A couple of days after the Olympics are over, you figure out that only 2 of these team members here had any sort of disability at all. That is awesome. Trust no one. Yes, they're all supposed to be. It's a Paralympics. So these guys whooping people by like 30 points and you wonder why, right? Not cool. So when something doesn't look right, what's the message? There's something, there's a reason, right? Investigate. Trust no one, don't trust your lab, don't trust your patients, don't even trust yourself sometimes, right? All right, any questions? Hey, so test Monday. All right, I still own you for a minute. Hang tight. Hang tight. And when you actually start reviewing all this stuff, obviously if you have questions over the weekend, again, please yell at me. All right, I'd rather hear from you on the weekend than have to remediate you after the class. 2-second review. 2-second review. Cellular growth factors, yeah, risk factors, modifiable, not modifiable. Your cancer screening we talked about, tumor markers we talked about, general principles of chemo. So there's a couple drug questions on there, right? I don't get into R-CHOP and ABV and all that crazy stuff, but yes, there's a couple treatments where you're gonna have to know what the treatment option is, right? So again, think as you study, what's the pathways behind the disease? How does the disease present? And then what's a reasonable treatment that I could have for you guys, right? I'm not gonna ask you like the 12 drugs of R-CHOP and ABV, right? The disease processes, myelofibrosis. What's the abnormality there? What's the pathophysiology behind myelofibrosis? How does it present? All right, polycythemia vera, same. What does that present with? All right, what are your key markers for each of these? And think back to on that patient we talked about at the start of class, right? Patient presentation. What's my differential? And how am I gonna narrow that differential down? And then as you read through these, right, look at them from the standpoint of what we just talked about, but then there's some key factors for each one of them. Make sure you know the key factors. CML. When you think CML, what do you think? Philadelphia chromosome, triphasic disease, blast crisis, right? What's the other name for their blast crisis phase? What's your blast crisis? Acute, right? Did I have the slide in here? Did I slide it? There are about 12 questions off of that slide. Probably 19, but again, right, so how do you distinguish these, right? Age, sure, right? Common things being common. ALL is typically who? Kids, right? And then myeloblast versus lymphoblast. Again, go back to this question in the morning, right? You had this patient, presented with a bunch of cancer symptoms. He had some anemia, he had some low platelets, he had an elevated white count, which should have put you down the range of a leukemia. Right? And then how are you gonna tell one leukemia from the other? Acute versus chronic, lympho versus myelo, right? Please be able to go through that in your brain. And then CLL, most common, sure, indolent, right? Talk about these, and we talk about with Richter transformations. Right, what else? Hodgkin's, non-Hodgkin's. Again, be able to differentiate a Hodgkin's versus a non-Hodgkin's. And then the MGUS and the multiple myeloma stuff, right? You start with the MGUS, transition to smoldering, transition to multiple myeloma. Be able to, if a patient presented on any one of that continuum, right, be able to identify where they are in the disease process. And everything else that goes along with everything else. So what are the associated labs? What does a lab look like? What does a lab look like in an AML patient? Alright, so blast, right, is the hallmark. Anemia, probably, plus or minus low platelets. White count could be variable depending on where they are in the disease process. Right? Again, MGUS in these, you know where your labs are. What's your protein values and so forth. Right? How do I manage patients? Yep, you guys know all of that already. Calcium, corrected calcium. No, I will not put a corrected calcium test question on there. I do not want to insult any of your intelligence. You guys are capable of doing math. I believe you. And if not, you got calculators. Right? Spinal cord compression, all the oncologic stuff, right? You know, I love emergent stuff. Compression, neutropenia, yes. Tumor lysis syndrome, yes. Right? I forgot that was in there. 3-year-old. All right, so stop right there. 3-year-old. What does that start like at the start? Yeah, so kids. All right, so that's at least in my differential, right? It's high in my differential. Intermittent fevers, fatigue, bruising, pale appearance. What do you get from that? So he's got some anemia. He's got a fever, intermittent, coming and going, fatigue, bruising, right? What is bruising and all that stuff without injury? So probably low platelets, right? Probably some thrombocytopenia. All right, physical exam, palpable liver, spleen, Pale conjunctiva, initial lab test reveals white blood cells out there.
Lymphoblast.
You got some lymphoblasts in there. What does that tell you? What's the disease process?
Acute infection.
ALL. So you got a kid with lymphoblasts, right? So ALL. Which of the following used to confirm the diagnosis? How are you going to confirm? Bone marrow? Does this sound like this is making sense to you guys? I see some head nods, man, but I see this look behind the eyes that makes me very, very nervous. I tell you, on test day, I am literally more nervous than you guys. Like, I'm not nervous when I take tests, but I'm nervous when you guys take tests. This is a bad thing. Bone marrow biopsy, right? So if you can see your way through this, you're on the right track. If you can't see your way through that, you're not on the right track. 16-year-old, follow up for fever, prolonged fever, fatigue, night sweats, lost appetite. Again, what does that sound like?
Cancer.
Yeah, it doesn't sound good. Physical exam, febrile, enlarged cervical lymph node, painless rubbery lymph node. She's referred for what? Biopsy shows Reed Sternberg. Reed Sternberg cells. What's the answer? All right, you guys said that with confidence. All right. Hey, so between that question and those questions, it's kind of there. And then you gotta know some of the nitty-gritty details, right? And you gotta know about all your screening stuff and yada, yada, yada. Basically, anything in black ink is testable. Right? Any questions? All right, as you guys go through this, seriously, if you have any doubt, just come find me. All right, I'm gonna be in and out this week. Like, I got a part-time here and part-time over at like Big Navy around the corner. All right, so text me if you need me.
Anything about the questions coming back?
Still ruminating on it. Still ruminating on it. And the med techs are like yelling at me like, get off your the time frame. All right, let's just pull the plug and call it as is, then I'm good. Let's end the rumination. I like the way you think, shipmate. I need to get off my backside and make a decision. Let's do it. Make it so. You got what you got. Have a nice day.